we had to a bit hurry the rheumatology session because we have a national conference tomorrow, and all the three of my previous speakers are leaving by the Vande Bharat at 6:25. So, but I'm leaving only tomorrow, so it's not a problem for me. It's nice to actually sit with Dr. Tambu after 20 years and to see Dilip Patai sir and Kurian Thomas sir and Anand in the same room. 20 years sitting in the same room together. It was nice. So why we just thought of presenting on neuropsychiatric lupus is because lupus is one of the probably, it's a rare disease, but one of the common problems we see in a tertiary care center. And the lupus, as we know, the cutaneous manifestations, the hematological manifestations, renal manifestations, we see the tissues, we know what's happening, we understand the disease very well. But unlike this, the neurological manifestations, obviously you can't biopsy the brain, or you don't have to. The downside is we don't understand the disease as well as we understand the other manifestations of lupus. So that's what we thought probably we would take on what are the immune possibilities in neuropsychiatric lupus. And this is a 1999 classification criteria for classification of neuropsychiatric lupus, and which still mostly holds good, except one or two additions which we see. Things which this doesn't have is like neuromyelitis optica spectrum disorder or small fiber neuropathy. But this like 12 classifications of central neuropsychiatric lupus syndromes and 7 peripheral neuropsychiatric lupus syndromes. And some of the average presentations of these manifestations are given there, commonest being in diffuse central cognitive impairment and mood disorders, in focal headache to seizure disorder to cerebrovascular disease, and peripheral neuropsychiatric manifestations as such are less common, but mononeuritis multiplex, GBS, and autonomic disorders could happen. Coming to the pathophysiology, when we get a patient with lupus, obviously, neuropsychiatric lupus is a diagnosis of exclusion. So you make sure you don't have a metabolic problem, you don't have an infection for which the patient has come to you. And once we have ruled it out, then whether it's a complication of the immunocompromised state of the patient, either because of lupus or the lupus-related treatment. And the other, it could be the primary pathology due to lupus, which could be a vasculitis or a vasculopathy, or an antiphospholipid antibody syndrome, or it could be a demyelinating syndrome, or an autoimmune-mediated encephalitis. Yeah. Point. Yeah. So basically, in a simplistic manner, we could put the pathology as either it's an ischemic process or an autoimmune process. The ischemic process could be a vasculitis, vasculopathy, or a vasculitis meaning inflammation across the vessel wall, while in vasculopathy, you don't have inflammation across the vessel wall, just what happens inside the lumen, or thrombotic episode, or an immune complex deposition causing complement activation and vessel damage. And these ischemic processes could lead on to focal NPSLE or diffuse neuropsychiatric manifestations. And the autoimmune process obviously would be the process related to the adaptive immune system. Simplistically saying, it's the adaptive immune system producing autoantibodies. These autoantibodies can produce antibodies like antiphospholipid antibodies or anti-endothelial cell antibody, which could again trigger the ischemic process. Or the other antibodies, the several antibodies, which could cause neuronal damage. But something which stands between the autoantibodies and the damage, NPSLE, is the neuroimmune interface permeability. as we all know, as we commonly know as the blood-brain barrier or whatever it is, which prevents the neuronal damage in patients. But if there is, for some reason, disruption of the neuroimmune interface permeability, the antibodies have access to the brain parenchyma or the neuronal tissue, which can cause NPSLE. And as I said before, one of the problems with NPSLE is you don't have tissue to study the pathogenesis or the process happening. So all what we know about NPSLE is mostly from mouse models. And actually, the first two ones are the most important mouse models generally which we use in lupus. The first one is the MRL-LPR mice, which has a rapid presentation of lupus and neuropsychiatric lupus. So for disease processes like acute confusional state, use that mice. Or the second is the New Zealand black-white mice cross. This is the first generation of a black and a white New Zealand black and white mice, where you can study better the neuropsychiatric disease or the way the disease progresses in this New Zealand black-white mice crosses. Slowly, the neuropsychiatric manifestations progress slowly as it happens in human beings. And the appropriate regions of these mice can be studied. But one point to remember is, even in mice, you need to disrupt the neuroimmune interface by some laboratory mechanism for the pathology to happen in the mice. So both these mice are prone for lupus, but in the lab, you disrupt the immune interface so that you can study the manifestations of the disease. And the other two mice models, 564IG1 and C57B1, they are less common models, rarely used, first for a specific type of anti-RNA polymerase damage to the brain, and the last one for genetic mutations in the neuropsychiatric lupus. So as I said, the neuroimmune interface is so important. And so this is of the neuroimmune interface. The most important is, one of them is the meningeal barrier. So basically, you have the blood vessels in the subarachnoid space, and you have to have some disruption of the meninges for the autoantibodies to breach the meningeal barrier. And one of the common ways by which we could breach the meningeal barrier is the lupus itself. We know lupus serositis is one of the common manifestations of lupus. So this can cause meningeal inflammation, which can, then the antibodies can cause the blood-brain barrier. So that's why it has to be treated to prevent the antibodies crossing into the brain parenchyma. Or it may be as simple things like there are so many reasons why you can get an aseptic meningitis. Even your anti-inflammatory medications, you give NSAIDs, you get aseptic meningitis. And this meninges, the blood-brain barrier, easily permeable, and this can cause worsening of or can initiate your neuropsychiatric lupus. So the other barriers which we have studied, which people have studied, is the G lymphatic circulatory system. So basically, you have the blood vessels, and then you have this neuronal tissue, and you have these astrocyte feed processes, which are like tight junctions, which prevent anything from the blood vessel going into your brain parenchyma. But for some reason, this potential space is disrupted. It allows the immune cells to pass across. Similarly, the blood-brain barrier, which you have the blood vessels inside the brain, surrounded by the pericytes, and you have the tight junctions of the astrocytes and the basement membrane around the endothelial cells. All these prevents the disruption or the entry of the autoantibodies into the brain parenchyma. But when you have a breach in this blood-brain barrier, which could be due to infection, just stress, or you have specific anti-endothelial cell antibody. So one of the postulates is lupus, it's like a museum of antibodies. So you can have anti-endothelial cell antibody, which can cause disruption in the vascular endothelium, which will increase the permeability across. And then you have the blood CSF barrier, which is basically along the choroid plexus. So you have, again, the tight junctions of these epithelial cells, and the basement membrane, which prevents the antibodies in the CSF from the blood vessels going into the CSF. But yeah, so these are the 4 barrier processes which are thought to prevent development of neuropsychiatric lupus in patients with lupus. Once you have the barrier disruption, so what happens, as in any lupus patient, you have systemic production of antibodies, goes across the to the neuronal tissue, and once they reach the neuronal tissue, depends on which surface antigens on the neuronal tissues are affected, they can cause damage. It can be the nerve cell per se, or it can be the astrocytes, or it can per se damage the myelin. So broadly speaking about the pathogenesis, and coming to the specific antibodies, antiphospholipid antibody, all of us know that it can cause thrombotic event and cause antiphospholipid antibody syndrome, which is basically the prothrombotic microparticles by the activated cells process that. But even without a thrombotic event, patients with antiphospholipid antibody have increased incidence of seizures, chorea, or cognitive dysfunction and myelopathy not related to a thrombotic event. And so that is one thing which has been observed. And those with when there is a thrombotic event, as we have discussed before, that causes a disruption of the barriers, and that then promotes a neuropsychiatric event. And those with antiphospholipid antibody are twice as likely to develop NPSLE than those without. And there is another paper in 23 where the risk of stroke in individuals below 50 is almost 8-fold higher in those with APL antibody positivity compared to APL antibody negative. And so then another thing we all know is long-term lupus. One of the risks is cardiovascular mortality. And the those lupus patients with antiphospholipid antibody have an accelerated atherosclerosis. Now coming to the anti-NMDA receptor antibodies. It's basically a subset of your anti-dsDNA antibodies, which cross-reacts with your NR2 receptors, like NMDA receptor 2A and 2B subunits of these postsynaptic receptors. So these binding to these postsynaptic receptors in the neurons will lead on to neuronal death, and primarily the damage to the receptors, which causes increased calcium influx, and it is like a glutamate excitotoxicity. Then coming to anti-ribosomal P protein antibodies, and this is present in up to close to 50% of patients with lupus. And when you have anti-ribosomal P protein high antibody, you have a higher incidence of psychosis, depression, seizures, coma, transverse myelopathy, and aseptic meningitis. Basically, these attaches to the neuronal receptors, basically neuronal surface P antigen, and these antibodies cross-react to those antigens. That is one way which can cause a pathology. Basically, these are P proteins attached to the ribosomes. And not only that, these antibodies can induce TNF production by your macrophages and microglia inside the inside the CNS. So a patient with anti-ribosomal P protein antibody gets a high incidence of neuropsychiatric manifestations. An anti-endothelial cell antibody, which again I had mentioned before, which is important in causing endothelial damage in anywhere in the central nervous system, which promotes all your autoantibody related damage. And anti-endothelial cell antibody also is postulated, it could be a prothrombotic starting event. And this is one of the data which is obtained is more than 60% of patients with NPSLE have with anti-endothelial cell antibody have NPSLE compared with those without. And then microtubule associated protein to antibodies. So this is thus it has been detected to have antibodies, and what is the significance of this we yet to know. So also anti-suprabasin antibodies, which are again in high titer in patients with NPSLE compared to lupus patients without NPSLE. So we tried to look in a department, we tried to look at the several other antibodies whether there is an association with NPSLE. This is a paper we got published in this year's Lupus. So we did a cross-sectional study from 2019 to 22 of our NPSLE patients. And we looked at the anti-neuronal antigen panel. And this was done by a semi-quantitative line immunoassay in our microbiology department. And we recruited, there were 13 different antibodies which we looked at in this line immunoassay. And we had 65 patients were recruited, and of which, of the 65 patients, 23 had active NPSLE at the time of recruitment. And anti-neuronal antibodies were present in 20% of the patients. 13 of the 65 had anti-neuronal antibodies, and these are the different specific antibodies which were found positive in our NPSLE patients. But one of the observations we had is, if the patient had an active disease, then the chance of having anti-neuronal antibodies, the odds ratio is almost 10. So if you have any of these anti-neuronal antibodies, the possibility of the patient having active NPSLE. So whether it indicates, or whether you can use it clinically, we're not yet sure. We haven't seen any other data like that, but this is one of the observations we have made in our department. And the same 65 patients, I just tried to put it as like the mean age was 27, and the duration of lupus for those patients were 36, and the duration of NPSLE was short, like 1 month. Basically, that's when they come to a tertiary care institution. And these are the different manifestations which we had in our group of patients. So coming from that to another group, the demyelinating syndromes, where you have the myelin sheath being attacked by your immune system, which leads on to demyelination. And or there is a damage to the astrocyte. It's the astrocyte which supports the myelin onto the neuron on the nerves. And once the astrocytes are damaged, the myelin sheath loses their support and they can get damaged in turn. This is basically an MRI showing optic neuritis, which is again a demyelinating syndrome. So the demyelinating syndromes can be like a neuromyelitis optica with different levels of the brain involved, or predominantly involving the brain, or it could be predominantly involving the brain stem. Can anybody guess who this is? And what is the thing shown on the cell? Any quizzes? So this is Dr. Peter Agger. It's a physician scientist. So he had the Nobel Prize in 2003. So what is the other thing? Sorry? No, this is a water channel. Actually, water is basic, water is basic for any eukaryotic organism or higher organism, and including animals and plants. And so Peter Auger discovered this water channel. Basically, it's just a water, like it's an aquaporin, basically, aquaporin which transmits water across different cells or between body fluids and the cell, and which is so important for any living organism. And so for that's, so he got the Nobel Prize for this. And so then you have, neuromyelitis optica spectrum is something which you have been knowing for long. But so where does it happen? For the PG sake, wherever you have the brain CSF, like have the ventricles, you have it in the area behind the area postrema, the spinal cord. So where you have the choroid plexus, so there you have filtration of water from the CSF into the brain parenchyma, for which these aquaporins are important. So if you have damage to the aquaporin, or by any reason, or if you have antibodies against aquaporin receptors, that can cause disruption of the fluid entry into the brain parenchyma, and which can cause damage. So what happens is, once you have the aquaporin antibodies, so these are the aquaporin antibodies. These astrocytes, which normally holds the myelin and the vascular membrane intact, gets disrupted. So then you have, it becomes messy, and all your water can enter in. Along with that, the inflammatory cells and your antibodies can enter into the parenchyma and can cause damage. So that is what happens in neuromyelitis NMO spectrum disorders. And some patients, NMO as such is a different entity where you have actually almost 75% of people have aquaporin antibodies. About 20 to 25% patients may not have an antibody. We don't know whether it's because we are not able to detect it. Even this 75% depends on how you do test for the antibody. And ideally, you should test it by cell-based assay, where it is very sensitive. And with cell-based assay, currently we have like 75% sensitivity of anti-aquaporin antibodies in these NMO spectrum disorders. And a minority of patients with SLE who develop demyelinating lesions are very typical of NMO. And taking all patients with NPSLE, anti-aquaporin 4 antibodies are detected in 3% of patients. And those NPSLE patients with demyelinating disease, anti-aquaporin 4 antibodies were almost in 27%. So we spoke in lupus and brain damage. We spoke about the the barrier between neuroimmune interface. Second, we spoke about the antibodies. We spoke about how the antibodies could come into different brain tissues and cause damage. And third, it's not all about it. Obviously, there is inflammation in the brain, cell-mediated inflammation. Again, we don't know how the human brain it happens. What we know is from the MRL LPR mice. And the leukocyte population within the cerebral vasculature contains substantial number of inflammatory T cells. But again, this is in the vasculature of the mice brain, not in the parenchyma. And another observation is there is prominent cell infiltration of the choroid plexus, including the helper T cells and plasma cells. And beyond this, the microglia, which are again the immune cells in the parenchyma, are potent cytokine producers, and which can cause synaptic loss. When you have a neuronal synapses which are lost, like you get cognitive disturbances and high function abnormalities when you have the synapses between the neurons lost. And there are some other observations where when mice with neuropsychiatric changes have increased levels of multiple cytokines. So basically, it's the cell inflammation, and then the cytokines are involved. And when you try inhibiting some of the cytokines like IFN alpha, you have drugs like anifrolumab, which have been tried in other conditions, other manifestations of lupus like nephritis. So because there are high level of cytokines, and in mice models, you try blocking the IFN, give IFN blocker inhibitors, the mice tend to have subdued neuropsychiatric manifestations. Another observation in human beings is the intrathecal levels of pro-inflammatory cytokine IL-6 have been high in patients with diffuse NPSLE. This is a human model, human observation. Now, the fourth thing is complements. Again, this is again from MRL LPR mice model. And if you block the complement cascade, it reduces the inflammatory cytokines. It reduces the cell adhesion molecules. Basically, adhesion molecules across the endothelium makes the inflammatory cells, your leukocytes and your monocytes, to adhere to the vascular endothelium, and which can cross the vascular endothelium. So you block the complements, and then your adhesion molecules tend to come down. And again, diminished cell apoptosis. And complement 5A could be involved in disruption of this blood-brain barrier. Why these are important is you have drugs coming which could target each of these molecules, which could be potential therapeutic options in neuropsychiatric lupus. So just a summary of what I said. So you have the blood-brain barrier, and you have the brain vascular interface, and then you have the anti-endothelial cell antibody, which is found in 60% of patients with NPSLE, which adheres to the endothelial wall, which triggers the adhesive cytokines like cell adhesion molecules. And once we have the cell adhesion molecules, we have these inflammatory cells like the B cells and T cells adhering to the endothelium, and then they cross into the parenchyma. or the immune complex also, which is formed in the vessel, can cross the endothelium and enter the cell parenchyma, which can cause then a inflammatory immune response. And the inflammatory immune response by the T and the B cells produce various cytokines. And it's important to know because you have many already drugs which are used in different conditions, which can block these cytokines. So these cytokines, particularly IFN gamma, all these things are produced which can be blocked, which are all therapeutic options for lupus. This again in detail, probably one just addition is microglia again are important immune cells in the parenchyma, which can produce many inflammatory cytokines, which so inhibition, which could be a therapeutic option in neuropsychiatric lupus. So summarizing, finally, as a clinician, so somebody with neuropsychiatric lupus can have many non-specific manifestations which you treat symptomatically: anti-epileptics, anxiolytics, antidepressants, mood stabilizers, or antipsychotics. Or lupus-specific, it could be activation of the inflammatory pathway, the treatment of which is immunosuppression. So again, the sheet hanger is glucocorticoids or drugs like cyclophosphamide, azoran, mycophenolate, or biological agents. Rituximab as of now. Maybe anifrolumab is the anti-TNF alpha, which I had mentioned, or belimumab, which is available in the West, but no good data on that. Or in patients with ischemic pathway damage, you can use drugs like aspirin, as we all use, like aspirin, heparin, warfarin, or whether oral anticoagulation. Whether biologicals like rituximab have a role in the ischemic pathway is yet to be proven, but possible. So that's a brief summary of neuropsychiatric lupus.